But I think smoldering MS is a term that I want us to use, and I'll explain to you why in this talk, why we want to use it. But recently, we've had 2 drugs licensed for progressive MS. We had ocrelizumab come out first for active primary progressive disease, and we've just had a drug licensed in Europe, and it's also licensed in the United States for the same indication, but in the secondary progressive phase, active secondary progressive. And I think we need to challenge those 2 terminologies, and I'll explain to you why. I do have a large number of disclosures, and I sit on the steering committees of both ocrelizumab and siponimod, and I'll be speaking about both those drugs in this talk. So the dogma, as you know, is that focal inflammatory lesions drive all the pathology. So when you get an acute lesion, you get axonal transection, demyelination, which causes a relapse, but that then sets up the substrate for the cascade downstream. So we get delayed neurodegeneration, which we think may be due to demyelination. We get the so-called hot microglial, or the change in the microenvironment in the lesion that causes post-inflammatory neurodegeneration. And because we reduce the number of axons and neurons, we set up this process for premature aging to go in. So everybody says if we can stop the upstream events, we will prevent all the downstream events. Would you accept that as the dogma? That's kind of the dogma that's been put forward. You're smiling. And so active MS drives everything. And I'm going to challenge that today and explain to you I don't think it's correct. So I'm going to give you a few case studies because I want to make this interesting for clinicians. So these are the case study. These are hypothetical, but I see them in my clinic almost every week. So this is a 36-year-old male, had MS for 12 years. He was previously treated with interferon and broke through. We have that. Switched to fingolimod 3 years ago. His last relapse was prior to going on to fingolimod. And while he's been on fingolimod, he's been stable. So no relapses, no MRI activity, and his EDSS is stable. But when he comes into clinic, he tells you, I'm not stable. When I go running, my foot drops. Okay, and he's been collecting Fitbit data, and he shows you his Fitbit data that he's actually getting worse over time. So the question I want to ask you is, does this patient have secondary progressive MS? Don't have to answer it. And does he have active secondary progressive MS? And is this patient eligible under our current guidelines to switch to siponimod? Okay, so this patient is NIDA 3 based on our EDSS, MRI, and relapses. But he's definitely not inactive in the sense that he is getting worse. Common scenario? This is actually what we see almost every day in clinic. Let's change it a bit. So now he's stable, except that this particular unit, and it could be, I went to visit a center in Belgium, in Antwerp, where they've been using MRI brain volume metrics for the last 4 or 5 years from icometrics. And they've got these patients that are losing quite profound brain volume every year, despite being stable clinically. So this gentleman is losing about 0.8% per year, which is probably at least about 2 to 3 times what you'd expect. Okay, and the question then is, does this patient have secondary progressive MS? And does he have active secondary progressive MS? And would he be eligible under our current criteria for switching to a licensed therapy for active secondary progressive disease? Think about the answers to these questions in your own head. And then as a prelude to this, so this patient actually is NIDA 3, but he's not NIDA 4 because he's got, NIDA 4 refers to brain volume changes because his brain volume is above the 0.4 cutoff that we try and promote for this concept of no evident disease activity for. And the final version of this case is he's stable, but he's noticing increasing forgetfulness at work, and it's difficulty using software, a new software application. And because we've been monitoring him in clinic using the MS functional composite, we noticed that his upper limb and lower limb function are stable, but his STMT is deteriorating, and you can see he's dropped from 48 down to 39. He's lost 9 points over 3 years, and the people who work with the STMT say that anything above 4 points is clinically meaningful because it affects quality of life and occupational functioning. So this gentleman has got progressive cognitive for you. It's got MS dementia, essentially. Now, Dawn Langdon will be talking about this later on this afternoon. You know, can we use cognition to define secondary progressive disease? It's quite debatable. Can we do that? So again, does this patient have SPMS, active SPMS, and is he a candidate for switching? I see some people are looking like they don't agree with me here. So we know this patient's not NEDA 3, but he's deaf, but he's not NEDA 6. Some people want to put cognition at NEDA 6. Not uncommon scenarios in clinical practice. So I want to actually give you a real patient, and this is actually a patient who's given me permission to talk to you about it. Actually, she's a vet, and she had pretty bad MS, and we treated her with alemtuzumab, and she failed alemtuzumab because she had anti-drug antibodies. We put her on to natalizumab, and she's been really well on natalizumab in terms of being stable. Okay? So she's NEDA 3 on natalizumab, having failed alemtuzumab. However, she has noticed, and we have been measuring her upper limb function because we started about 2 years ago, and she has noticed that her upper limb function is deteriorating, and we've detected on our non-all PEC tests. And so much so now that she can't do surgery. She's had to give up veterinary surgery, so she's now actually retrained herself as a small animal vet that doesn't do surgery anymore. So this lady is absolutely getting worse with upper limb function, and we're not detecting it in the EDSS score. So the question she said to me, you tell me I'm stable and inactive, but I'm getting worse, and the question she asks is why she's getting worse. Okay? And so where does she fit into this classification system? Because I'm convinced this lady has got secondary progressive disease. Okay? And so this is the classification system we use at the moment. We divide up secondary progressive disease into those active with worsening, active without worsening. And on the relapsing side, we don't have a worsening bracket, we just have not active, not active. So what's wrong with this classification system?
It's artificial.
Because this is what we use now to define activity, and I'll come back to this. And so this is why I wanted to thank Gabby for giving me this slide, but your presentation just completely illustrates why pathology is so important, because Gabby's just showing you the literature that all these patients that are inactive, that we classify as inactive, are actually active when they die and come to postmortem. The majority of them have ongoing active inflammation, but we as clinicians are telling them they're inactive. So we actually went out to the community using our blog and did a survey and asked them to give us a term on what to call this. We gave them a few options, and so they voted overwhelmingly to call this state where they are in, where they NEDA, obvious inflammatory activity, but getting worse. What should we call it? And the two things that won out was progression independent of relapses, and I assume that term has gained popularity and traction because of various publications, or smoldering MS. Now, I personally prefer the term smoldering MS is because PIRA really only refers to relapse onset disease, and it excludes the primary progressive population based on definitions. So I would like to call this smoldering MS. And the smoldering captures the term. It tells you what smoldering is. You have a hot environment, and behind there's smoldering, and this is what's happening in Australia right now. The whole of Australia is smoldering. Okay? And I was criticized for using this term, but I didn't invent the term because the pathologists have been talking about smoldering lesions for a long time, and this is an editorial in JAMA Neurology, JAMA, around the slowly expanding lesion, which they call the smoldering lesion, and I'll come back to that. What is smoldering MS? So we identified very early, so you all probably know about progression independent of relapses. When you do have a relapse, you can actually recover or not recover, and we call that relapse-associated worsening. But what's important is that even in the relapsing phase of the disease, a lot of people progress independent of the relapses. You can re-baseline the disability after the relapse and show worsening. And we see this now despite being on highly effective treatment. So this is actually natalizumab, and you can see the majority of worsening that occurs in people on natalizumab has got nothing to do with relapses, because this is one of our most effective therapies at switching off relapses. And so the worsening then is independent of relapses. Okay. And we've seen that similarly in the ocrelizumab relapsing population. This is the Rebif arm. Okay. 78% of the worsening was independent of relapses. And in the ocrelizumab arm, 88% of it, because ocrelizumab is better at switching off relapses than Rebif. And you can actually look at these another way of looking at it, you can see these like Venn diagrams, and you can see the white space is what we want to achieve, but there's a lot of activity that's occurring that we need to suppress. So I actually think this classification system is wrong, and what we should actually also add on this side is worsening. So you can still have, under the current classification system, relapsing disease that may be stable or worsening, which means that the progressive phase of the disease is there from the very beginning, and so we should actually get rid of this classification system, if you don't mind. I hope you're going to help me, Bill. We know from the MRI studies, apart from the pathology studies, that brain volume loss, which we think is the end organ marker for this phase of the disease, is there from the very beginning of the disease. And if Maria Pia Amart is still in the audience, we can actually add the same thing happens in radiologically isolated syndrome. So right from the very beginning of this disease, even the asymptomatic phase, there's significant brain volume loss, gray matter pathology occurring. Okay? So the substrate for what we call progressive disease is there from the beginning. That is the disease. So there are pathological drivers, and I'm not going to spend time going through them. There's demyelination, the microglial hypothesis, the B and plasma cell hypothesis, the iron and energy failure hypotheses. So there are lots of potential treatment targets to tackle this phase of the disease. Demyelination, just to say to you that there are a large number of drugs that have been through or in clinical trials. I highlight 3 that are really high-dose biotin, which has been to promote remyelination and improve energy in terms of conduction, is about to report out in the phase 3 program. I sit on the steering committee. Opasunemab, which is anti-LINGO-1, we in the phase 2b study is fully recruited. We're busy designing the phase 3. It's extremely difficult to design a trial at a phase 3 level of disease improvement that the regulators are going to accept. That's one of the problems we're having on the steering committee. And this is one of the molecules that excites me the most, elazunumab. This is anti-retinal, repulsive guidin molecule. This is a drug that AbbVie is developing. And the basic science data behind this is so exciting. Okay? Most of it comes from the spinal cord field, but this is now in phase 2, and hopefully a phase 3 program will follow. But it's exciting. We've got drugs that are targeting remyelination as neuroprotective drugs in the MS space. The mistake we're making, I don't know if you're aware, but if you look at the spinal cord literature, they wouldn't be doing these trials unless they put focused rehab and exercise on top of this. We're not doing that in the MS space, and I think we're going to pay the price for not including rehabilitation on top of remyelination strategies. So if we get a negative study, we may worry about the fact that we haven't actually tried to rehab that pathway, because rehabilitation is very important in stimulating recovery mechanisms. Hot microglia, you probably know a lot now about this lesion, which we call the smoldering lesion or the slowly expanding lesion. It's there. These lesions are interesting. They don't enhance. They often, they can actually emerge from no previous gait-enhancing lesion or no new T2 lesion. What's important about them, though, is they get gradually bigger over time. And it takes years to decades for these things to expand compared to the lesions that don't expand. So they're a different beast. What's causing the slowly expanding lesion to expand is a different beast to a T2 or T1 lesion that doesn't expand. So there's something ongoing in that lesion which we don't know what's driving it. We don't know what's driving it. We do know that ocrelizumab in the primary progressive trial had a small effect on slowing down these slowly expanding lesions, which makes me think it may have to do with B-cell biology, immunoglobulins. We don't know. What was quite frightening was this poster presentation from 2 years ago at ECTRIMS from Giovannoni's group, just showing you that in risk patients, asymptomatic MS patients, 3/4 of them already had slowly expanding lesion. They never had a clinical attack. So this pathology is also there from the very beginning. There's also a literature of these slowly expanding lesions occurring in very critical areas, like the corticospinal tract, causing progressive hemiplegias, for example. So they can be very, very disabling if they occur in a critical site. Anyway, we're planning a trial. I'm not going to go through it, but we want to use this drug, pioglitazone. So this is a PPAR gamma agonist. There's really good data of its interaction with dimethyl fumarate or the fumarates. It's CNS penetrant, and we think it targets microglia. And so we put an application in, we're about to put an application in to do an add-on, and this is where the mouse doctor, as David Baker, is completely correct. We want to do this as an add-on to an existing disease-modifying treatment to try and target slowly expanding lesions. So the real MS. So what is the real MS then? So we've all thought about relapses and MRI activities being the real MS. And this picture captures it. This is the long-term follow-up of the original Avonex, interferon beta 1a intramuscular. And you can see if you want placebo, relapses or GAD lesions or new T2 lesions didn't predict outcome. Didn't predict outcome. However, if you're on interferon, it did predict outcome at 15 years. Okay? What's wrong with it? What is that telling you? That's telling you that relapses and GAD-enhancing lesions cannot be the disease. And if you want to know the philosophy behind this, I suggest you read Prentice's book about what a surrogate endpoint is. And this tells you that it cannot, MS is not relapses, and MS is not focal MRI activity. If it was, it would predict outcome in both groups. And this is not the only data set. This exists prior to us having DMTs. So in natural history studies, relapses, except in the very early on, are very poor predictors of outcome. So MS cannot be due to relapses. I think the relapses in MRI activity is in response to what's causing the disease. Another clue comes from, this is data I stole from ECTRIMS. I wasn't there. Somebody took pictures for me because I couldn't go to the presentation. So this is actually the ofatumumab versus teriflunomide data. And you can see this is annualized relapse rates. Ofatumumab, an anti-CD20, is much better than teriflunomide at switching off relapses, 50+%. And you can see on an MRI, it's even better. It's almost 100% compared to teriflunomide in stopping focal MRI activity. Now, when you look at disability progression, much less impressive gap. Okay, that should translate into a much bigger gap. And when you get to the biomarker that's important, brain volume loss, then you re-baseline at 12 months, because at 12 months there's pseudoatrophy on these. There is no difference in brain volume loss between anti-CD20 therapy and teriflunomide. Okay? There's a massive disconnect here at what's happening in the tissue versus what's happening on the inflammatory immune response to what's causing MS. So this disconnect is telling us something fundamental about the biology of multiple sclerosis. The next one is B cells. I'm not going to go through it. You heard about it already. We think we should target this. Another clue, and Steve Hauser gave me permission to present these data. Did you see this data? It was presented at the American Academy last year. So this was looking at the response to ocrelizumab based on the blood levels. So, in a trial, you get thin people and fat people, short people and big people. The dose was fixed. So, but based on the size of the individual and their plasma volume, you're going to get different exposures to the 300 milligrams 6-monthly dose of ocrelizumab. So that you can then measure the amount of ocrelizumab, and you can actually put people into quartiles. So the people at the top quartile got the most exposure, and it actually reduced B cells more than in the people with the lowest levels. And when you look at actually the quartiles, based on quartile 1, 2, 3, 4, there was no difference on the impact of relapses. And similarly, when you go to the MRI metrics, there was no difference. So this is looking at the relapsing and the progressive population. You can see it doesn't matter what quartile you were in terms of ocrelizumab exposure. This tells you that ocrelizumab works regardless of your body size. But when you went to disease progression, there was a clear ladder. Those people who got the highest had much less disease progression. So there's a dose phenomenon with anti-CD20. The people who got the most dose did the best when it came to targeting disease progression. My interpretation of this is that there must be a tissue compartment that we need to deplete B cells. And it may have to be the CNS. These people may get more drug into the central nervous and get more central nervous system B cell depletion and do better. And because of that, I'm trying to, and this happened not only in the relapsing side, but also happened in the primary progressive population. So I don't think we've optimized the dose of anti-CD20 therapy in MS. And I'm very worried that with ofatumumab, which is subcut small dose, is not good enough in terms of getting into the central nervous system to target intrathecal B cells. So I'm trying to encourage Roche Genentech to take this further and do another study where we actually explore this further in terms of intrathecal anti-CD20 penetration to see if we're targeting those B cells. Energy deficits. So you all know that the demyelinated segment takes more energy, and there's some basic science, and I see Ken Smith sitting here. Ken's done all the pivotal work showing you that this particular axon is vulnerable to degeneration if it's overactive. And there's been some very good translational work done by Raj Kapoor and David Baker in animal models, which made us select phenytoin to try and protect demyelinated axons in acute optic neuritis. And you've all seen this data has been published. And we can reduce retinal nerve fiber layer loss by 30% by getting people onto phenytoin, a sodium channel blocker, within the first 14 days of acute optic neuritis. So this is proof of concept that you can protect demyelinated damaged axons in an acute inflammatory lesion with a sodium channel blocker. The question is the sodium channel blocker working on the axon or the microglia? Okay, because microglia also express sodium channels and are switched off by them. So we actually took this further in a trial. We did a secondary progressive trial where we put oxcarbazepine, which is a sodium channel blocker, into people with early secondary progressive disease. And we actually had a primary outcome with neurofilaments which didn't show a difference between placebo and add-on. But we did show that the patients that got oxcarbazepine did much better in terms of EDSS versus those that didn't get it. So this is one of the bits of data that actually questions whether a neurofilament is a neurodegenerative marker or an inflammatory marker. But based on this, we've also gone to Roche, and we want them to do an ocrelizumab add-on study with oxcarbazepine in primary progressive patients to see if we can actually boost that impact on disability progression using a sodium channel add-on blocker. I'm hoping to convince them they need to do this study. There are a lot of other targets. I'm not going to go through them, but there are lots of other add-on potential neuroprotective drugs that are being explored or thought about at the moment. My personal opinion, lipoic acid should definitely be on top of the list based on publications and basic science. Early aging. Unfortunately, life is a sexually transmitted, age-dependent neurodegenerative disease. And if I look at most of you in this audience, you're at the cusp, okay? Once you hit 35, it's just downhill, all right? And so there is this theory, and actually I think there's increasing amount of data to support this theory because MS clips cognitive and brain reserve, that it brings forward premature aging, okay? Brings forward premature aging. And I'll give an example. I had a patient referred to me from the north of England 2 years ago, 3 years ago now. And she had quite bad MS in the late teens, early 20s, with 3 bad spinal cord relapses. And she was actually quadriparetic, and she was bedbound for about 6 months before she had rehab and got going again. And she always had a weak leg and a bit of a drop foot. And it was stable until she was in her late 50s, and then she started getting progressive MS. And we interrogated her. We did MRI scans, lumbar punctures, and we couldn't find any evidence of MS activity. And she said to me, "Don't you think I'm just getting old?" You know, and she's probably right. What happened was the aging mechanisms kicked in, and that was causing her to get old. Anyway, so there was work that comes out of UCSF just showing you that telomeres, which are the end of chromosomes, as you know, as you get older, those telomeres shorten. It's an aging marker. And people that had short telomeres did worse. They had higher disability, and they progressed more rapidly than people who had long telomeres. So there is some evidence that aging may contribute to progressive or worse, delayed worsening. And because of that, you know, we all have a MS-centric view. You know, we want to create this sandwich of anti-inflammatory neuroprotection, remyelination, neurorestoration, but we shouldn't ignore the non-specific mechanisms that drive anti-aging mechanisms. And so I personally think in the next decade, we as an MS community are going to start focusing on these mechanisms in a lot more detail. I'm particularly enthralled with exercise. Bill and I were talking about exercise early on. I'm also really interested in the science of diet. Okay? And you probably saw the publication that came out from Robin Franklin's group showing that when you put mice on caloric restriction, or as it rats they used, okay, you can actually reverse immune senescence in oligodendrocyte precursor cells and promote remyelination. Similarly, there is data out there, not in MS, but ketogenesis does the same thing. The other thing, and metformin, which is a drug, does the same thing. All right? So maybe there's ways of hijacking anti-aging mechanisms as add-on treatments to delay or slow worsening. So will the real MS show itself? So I actually think the real MS is this, and this is irrelevant. It's not irrelevant, we need to stop it, but it's not, and I think we've been completely hoodwinked by the fact that we should be focusing all our attention on relapses, okay, and MRI activity, when what's happening is the smoldering MS. So I'd like you to support me in trying to get this terminology into the accepted and for us to debunk the Lublin classification. So I think the Lublin classification is outdated, not fit for purpose. Inactive MS is not inactive. Smoldering MS or progression independent of relapse are the preferred terms. There are pathological drivers for this, and I think there's evidence to support almost all of these on this list, and there's probably another list here I haven't put up. And the real MS is not relapse of the focal MRI, but rather smoldering disease, and the field hypothesis suggests MS is an inside out, and I took those slides out because I thought I didn't have time. But there's a lot of data out there to suggest that there's something in the brain that's causing the disease, and our immune response to what's causing multiple sclerosis is what causes the focal MRI activity and relapses, which disappear with time. I'd just like to thank the group for helping with all the work we do, and I'll take questions.